We'll be Life in the Fast Lane has got this fantastic 100 cases. It includes all these 100 cases of each of ECG, CT, USG, chest X-ray. Here we'll be going through all CT scans. So here is a case of 55-year-old male who was having self-terminating tonic-clonic seizure and several hours of confusion. So what do you see here? Basically, this is a CT scan, and what we can see is a 2 by 2 centimeter parenchymal lesion out here with surrounding vasogenic edema. So because of this lesion, since it is a round lesion, is most likely due to secondary hemorrhage. So whenever you're seeing an intra-parenchymal hemorrhage on the CT scan, you have to decide whether it's primary or secondary. If it's primary, it can be due to hypertension, and secondary will be due to all these causes like thrombosis, and intraparenchymal lesions, metastasis. So your primary hemorrhage can be due to hypertensive bleed or bleed from amyloid angiopathy. And secondary bleed is due to underlying structural abnormality. For example, there can be some tumor, venous thrombosis, or hemorrhage after an ischemic stroke. Now, why this round appearance is important? Round appearance tells you, and the presence or absence of surrounding edema is important. And these are the major clues in this CT. In this case, the hemorrhage has a very round appearance. And rounded appearance favors the diagnosis of secondary bleed, particularly an underlying metastasis which has bled into it itself. Whereas hemorrhage with an irregular shape would be more in keeping with primary hemorrhage. Then we saw the vasogenic edema. Again, this edema will tell you that this mass is there for some time, enough time to cause disruption of the blood-brain barrier, which then leads to leakage of fluid from capillaries. By contrast, primary hemorrhage will have no or minimal edema, as there was no underlying lesion prior to the hemorrhage. Again, the effacement of the adjacent cerebral sulci is a sign of local mass effect, and it tells us that there is increase in pressure causing compression on surrounding brain parenchyma. So the patient was found to have colon cancer, and this CT scan unfortunately demonstrates a cerebral metastasis with hemorrhage into lesion. Again, we look into the CT on the foot end. This is the left side, this is the right side. The most dense thing is the skull, which appears dark, white, hyperintense. Here you have an hyperdense lesion, the sulcal effacement. See the sulci grooves are all effaced, and then you can see this dark thing is the edema. So the next case is of an 70-year-old female who presented with 12 hours of duration of headache and progressive drowsiness. So this is a non-contrast CT of brain which is performed, and you can see abnormal place where the bleeding has occurred. So this is basically subarachnoid hemorrhage in the posterior fossa. On both sides, you can see this dark gray. So this is sort of an acute hemorrhage, and so diffuse subarachnoid hemorrhage within the posterior fossa. And typical locations of SAH are around the circle of Willis. So you can see the frontal lobe is here, and you can see this is the anterior cerebral artery. This is the anterior cerebral artery, the middle cerebral artery. The pituitary stalk will be seen in the center right here, and you can see the basilar artery. I hope you can see the basilar artery. Then you have the pons, the fourth ventricle. Okay. So these are the usual areas of berry-aneurysm in the subarachnoid. This was the posterior fossa berry-aneurysm, which had bleed, and it was grayish in color, so it determines the acuity of the hemorrhage. So ruptured berry aneurysm, most common cause of spontaneous SAH. And in this case, the distribution of blood is in the posterior fossa, suggests an aneurysm or vascular malformation involving the vertebrobasilar system. So this is a case is what are the other causes of non-traumatic SAH, subarachnoid hemorrhage to consider are perimesencephalic hemorrhage and amyloid angiopathy. The CT angiogram for this patient did not show an aneurysm. Instead, it shows an atriovenous malformation when they did an angio. And the appearance often referred to as bag of worms on the CT angio. Our patient was initially managed with external ventricular drain placement for management of evolving obstructive hydrocephalus. Once stable, she underwent successful endovascular repair. So here we'll see CT of a 75-year-old female found on the floor at home and reduced level of consciousness, and she was last seen well over 12 hours prior. So she has a background of atrial fibrillation on apexaban. On hospital arrival, she was found to have a GCS of 7 and a dense right-sided hemisphere. And the non-contrast CT scan of the brain and CT angiogram are performed. So what do you see here? So NCCT is here. And you have a CT brain angio. So here you can see a filling defect and here is much. So the ICA terminal thrombus, the CT perfusion, you can see, okay, left side seems less perfused. So how will you interpret this CT? On the non-contrast, there is no sign of intracranial hemorrhage. And there is reduced gray white distribution, differentiation in the left insular cortex and temporal lobe as well. However, there's a long hyperdense thrombus which you can see in the terminal left internal carotid artery and middle cerebral artery in the M1 territory. When you do the angiogram, like I said, there's absent blood flow due to thrombus and there's poorly opacified left common carotid artery. Poorly opacified left common carotid artery and the absent blood flow due to thrombus. Clinical correlation. Now these scans are an established infarct, which is not amenable to thrombolysis or endovascular clot. So it's a large infarct. And CT stroke series includes 3 phases. They do a non-contrast, an angiogram, and a perfusion study. Now, primarily, the CT non-contrast helps to exclude a hemorrhagic stroke or other pathology, and we do it because it is done fast. A hyperacute ischemic stroke may appear normal on non-contrast CT, especially if CT imaging is undertaken in less than 4 hours and reduced or loss of gray matter white differentiation is an early sign of acute ischemia or infarction. Then the insular cortex has poor collateral blood supply and ischemic occurs earlier here. For this reason, it is a good place to look for subtle signs of infarction as changes can be seen first. Also, you need to look for what? Hyperdense clot sign. So the acute thrombus within the occluded artery will appear hyperdense. And it is only occasionally visible. In this case, there was a thrombus seen occluding the ICA MCA. Then when we did the CT angiogram and arterial phase scan, it can confirm vessel occlusion and can also be used to guide further treatment, such as thrombolysis or interventional radiology. On this particular scan, there's also trap for young players. Note that there's only limited contrast within the left common carotid artery. So at first glance, this might be interpreted as a clot in the common carotid. Actually, there is no clot here, but it is just a sign of poor blood flow in the carotid. So the clots will be distal in the IC and MCA and are impeding the distal flow. This causes a pressure buildup, so it is difficult for the chronic media to reach the common carotid despite it being patent. So we are talking about this. The clot is distal to the MCA. Here the contrast is not reaching because there is pooling of blood. Okay, so there is a sort of stasis of blood where no contrast can reach. Or maybe it is reaching slowly. Then you have the CT perfusion scan, and this is used to distinguish between salvageable ischemic brain tissue, that is called as penumbra, and infarcted brain tissue, which is called as infarct core. So penumbra is a part of brain tissue that has compromised blood flow but has not yet undergone infarction. And infarct core, on the other hand, is the brain tissue which has already died and which cannot recover. So the degree of mismatch between the penumbra size and the infarct core is one parameter used to determine whether this patient will actually benefit from reperfusion therapy or not. So logically, patient will with small infarct core and large ischemia are the most likely to benefit from reperfusion therapy. So this is all for the CT series. Thank you.